Okay, guys, so we will be discussing orofacial pain, and we are continuing from our previous lecture, which was orofacial pain part 1. Orofacial pain is the specialty of dentistry, and that specialty, it encompasses the diagnosis, management, and treatment of pain disorders of the mouth, face, head, and neck. The specialty of orofacial pain is dedicated to the evidence-based understanding of the underlying pathophysiology, etiology, prevention and treatment of these disorders, and improving access to interdisciplinary patient care. This is according to the American Academy of Orofacial Pain, AAOP. Persistent orofacial pain refers to a group of chronic disorders affecting the face and mouth. It includes temporomandibular disorders, vascular disorders like migraine and cluster headaches, burning mouth syndrome, trigeminal neuralgia, persistent dentoalveolar pain disorder, and persistent idiopathic facial pain. Orofacial pain is defined as pain perceived in the face or oral cavity caused by diseases or disorders of regional structures or dysfunction of the nervous system or through referral from distant sources. Well, realizing the chronic pain itself is a disorder, it was a significant breakthrough in the medical field. Chronic pain disorders result from a complex interplay of biological, psychological, behavioral, and social factors. This led to the development of the biopsychosocial model, an interdisciplinary approach to treating chronic pain that encompasses both medicine and dentistry. Apart from that, there is a bidirectional and mutually reinforcing relationship between the neurobiological processing of pain in the central nervous system, as well as in the peripheral tissues, which include our muscles, joints, nerves, and the blood vessels. Here we can see our trigeminal nerve and its divisions and the areas which different divisions they are supplying: ophthalmic, maxillary, and mandibular. Then also nerves from the C2, C3, the cranial nerves, C2, C3, etc., etc. The cortical homunculus, or this tiny man or little man, which we call, it portrays the anatomical divisions of the primary motor cortex and the primary somatosensory cortex. We explain all the sensations on that. This is the cortex. Feeling of pain. Pain is based upon numerous biological, social, and environmental factors that the psycho and social model of the pain is increasing in evidence base. So looking at it, social and cultural, like age, children, and elderly, they feel more pain. Gender. Usually it is thought that probably female gender, they feel more pain. Then the race, peer support, and familial expectation. Then comes the cognitive and conceptual. Memories, past experiences, secondary gain, and threat perception. Then the emotional and psychological: depression, anxiety, stress, fear, anger, they also contribute towards the perception of or feeling of pain. Expertise in the field. Professionals who are being consulted for the diagnosis and treatment of orofacial pain should have knowledge in both medical and dental aspects of the condition. A physician who is knowledgeable only in medical pain management cannot address the peripheral causes sustaining the pain. Similarly, a dentist lacking understanding of the neurobiological and psychological aspects of the chronic pain will be unable to address the central nervous system components of the orofacial pain. If we look into the anatomy of the orofacial pain areas, teeth, mouth, tongue, jaw, maxilla, mandible, temporomandibular joint, muscles of mastication, cervical muscles, and joints, then cranial nerves, especially trigeminal nerve and cranial vascular system. We perceive the pain from all these areas. Here we can see the three divisions, which I told you earlier, and then various branches of the trigeminal nerve and their supply, that like the long buccal nerve, lingual nerve, then the mental nerve, and the inferior alveolar nerve, then its continuation as the incisive nerve, the posterior superior alveolar, middle superior alveolar, and we know that first permanent molar maxillary, it has very amazing anatomy. That the mesiobuccal root, it is supplied by the middle superior alveolar nerve, whereas all other roots, they are supplied by the posterior superior alveolar nerve. And then the anterior superior and the infraorbital nerve. Then we have the palatal branches, the greater palatal and the nasopalatine branch bilaterally from canine to canine, and then the lesser palatine nerve as well. So these are the branches of maxillary and mandibular division, which are supplying various parts of our oral cavity. Orofacial pain classification is based on the origin in this way. Somatic pain, which is originating from the cells of the organ involved, that is skin, mucous membrane, bone, joint, muscles, etc. Then the neurogenic pain, discomfort resulting within the nervous system, abnormality in the neural structures, there is no nauseous stimulus in that. Similarly, psychogenic pain, it is resulting from the psychic causes, there is no nauseous stimulus, no abnormality in the neural structure as well. Somatic pain, superficial somatic, deep somatic, and then visceral. So superficial somatic from skin and mucogingival area, deep somatic from the musculoskeletal area, muscles, TMJ, osseous origin, then periodontal origin. And visceral from the pulp, from gland, ear, and eye, and neurovascular origin. Three nerves of importance to us: trigeminal, facial, and glossopharyngeal nerves. They're both sensory and motor pathways are shown over here. Somatic pain. Somatic pain is usually acute and localized. It may be superficial from the skin or mucous membrane due to nauseous stimuli, for example, thermal or chemical burns, mechanical, ulcerations, infection, which could be bacterial, viral, or candidal or fungal. Then its character, it is burning, pricking, and localized. Deep pain, deep somatic from bones, muscles, joints, and ligaments. Eagle syndrome, which is due to calcification of the stylohyoid ligament. And its character is dull aching, could be referred pain as well. Then inflammatory from collection of infected fluid, for example, abscess, infected cyst, pericoronitis. Its character is throbbing with tenderness, tends to be localized. And referred from paraoral structures, for example, maxillary sinus, ear, eyes, and its character is deep pain. Neuropathic pain. It would be either episodic or it could be continuous. Neuralgias, they are episodic pains, and vascular pains, they are also episodic. Continuous, it would be due to neuritis, or it could be deafferentation pain. Deafferentation pain is that pain where the cause is usually not known and it is difficult to treat that or to control that pain. Neuropathic pain. Neuropathic pain is a type of pain initiated by the nervous system either from a lesion, trauma, or dysfunction. It can occur for no reason at all or can be secondary to other causes such as dental procedures or central nervous system pathology. Various types of neuropathic pain are neuritis, inflammatory change of the nerves, that is burning sensation, neuralgia, pain along the course of the nerve caused by vascular spasm and CNS diseases. Then vascular, it is usually poorly localized, chronic, preceded by minor electric shock-like pain. Causes of the orofacial pain. Local causes, somatic, neurological causes, neuropathic, then psychogenic causes, and vascular causes. Local causes, diseases of the teeth, diseases of the periodontium, diseases of the oral mucosa, diseases of the jaws, diseases of the maxillary antrum, diseases of the salivary glands, diseases of the temporomandibular joint, then diseases of the ears and diseases of the eyes, as well as diseases of the other sinuses other than maxillary antrum and of nasopharynx. Neuropathic pains. Trigeminal neuralgia, glossopharyngeal neuralgia, herpes zoster, post-herpetic neuralgia, then geniculate herpes, that is Ramsay-Hunt syndrome, Bell's palsy, multiple sclerosis, intracranial tumors, and causalgia. Psychogenic causes. Atypical odontalgia, atypical facial pain, and burning mouth. Vascular causes, migraine, periodic migrainous neuralgia, that is spinopalatine neuralgia, cluster headache, alarm clock headache, then paroxysmal facial hemicrania, giant cell temporal cranial arteritis, referred pain, for example, due to cardiac ischemia. Detailed history of a patient when patient comes to us for the treatment or maybe for the diagnosis of the pain they are suffering. We call it orofacial pain. So we take firstly the patient's details, their name, age, gender, male or female, then marital status and occupation, just like the normal history we take. Then their chief complaint or complaints and history of the present illnesses being asked. Their medical history, their dental history, then their psychosocial history. Chief complaints or chief complaint and history of the present illness. When the problem started, how long ago, what was the event of onset, then location, quality, intensity, duration, frequency, remissions or change over time. If there are certain modifying factors which alleviating, precipitating, or aggravating the pain, then previous treatment results, if any treatment being done, or even by chance they have taken some over-the-counter analgesics, so any response to that or not. Then their medical history. Current or pre-existing relevant physical disorders or disease, specifically systemic arthritis. Arthritis is the plural of arthritis. So any type of arthritis, that's why systemic arthritis, or other musculoskeletal or rheumatological conditions, sleep disorders and sleep-related breathing disorders, previous treatments, surgeries and or hospitalizations, trauma to the head and face, medications, prescription and non-prescription, allergies to medications, alcohol and other substances of abuse. Dental history. We take history about their current or pre-existing relevant physical disorders or disease, previous treatments, including the patient's attitude towards treatment, history of trauma to the head and neck, including any iatrogenic trauma. Iatrogenic caused by some dentist or some other medical personnel while performing some procedure. Parafunctional history, both awake and asleep. Are they doing some bruxism, clenching, or whatever during sleep or when they are awake? Then their psychosocial history, social, behavioral, and psychological issues, any occupational, recreational, and family status, like maybe they are involved in marijuana consumption or any other thing like recreational. Then going through some like litigation, any disability, or they are on insurance or like disability insurance issues, whatever, all these things, they are also a part of the psychosocial history. Orofacial pain of different types, their clinical features, diagnosis, and the treatments. Now, neuralgias. We will start with the trigeminal neuralgia. It is a self-limiting disorder characterized by instantaneous attacks of sharp, lancinating, shooting pain confined to the area of distribution of the trigeminal nerve and characterized by the presence of trigger zone. The etiology could be demyelination, vascular compression of the trigeminal ganglion, trauma or infection of the nerve, or it could be just idiopathic. Incidence, most commonly involving areas supplied by the maxillary and mandibular divisions of the trigeminal nerve. These are teeth, jaws, face, and the associated structures. Well, if we look into the age, more than 40 years of the age is most common when this condition it occurs. If it is affected patients below 40 years, then there would be a reason to it, and that could be like just suspect some serious underlying pathology, for example, some tumors, or maybe multiple sclerosis. Then females are affected twice more than males. The right side is affected more commonly than the left side. Mostly unilateral, bilateral is very, very uncommon. Mostly it is unilateral. The second division of the trigeminal nerve, that is maxillary, is more commonly affected than the third division, and ophthalmic nerve is only in 5% of the cases reported. That's it. Signs and symptoms. Signs: spasmodic contraction of the face muscles. Symptoms: pain is limited to one of the three divisions of the trigeminal nerve, most commonly second and third divisions. The pain of trigeminal neuralgia never crosses the midline. Remember that. Clinical features. Pain is described as sharp and stabbing, electric shock, red hot needle type. It is of rapid onset, short duration, and with rapid recovery. It is paroxysmal type of pain, and it occurs most commonly when a person wakes up and they wash their face, or they do gargles, or they swish their mouth before going for the breakfast, etc., etc. So it may start at that time. The pain of trigeminal neuralgia is as clusters. Patients have periods of regular pain and then periods of remission. This remission may last for days, for weeks, for months, or even at times for years. Trigeminal neuralgia does not affect sleep. So if a patient is giving you the history that I woke up due to pain, probably it won't be trigeminal neuralgia. This pain could be evoked by touch or even breeze to the trigger zone on the face or mouth, or it is evoked spontaneously in some of the cases. Trigger zone. It represents the primary site of origin for pain provocation. Half-inch finger signs. The patient points to the trigger area, but they don't touch. They are afraid to touch it because they may think that touching it, it may precipitate the attack. Diagnosis. Presence of the trigger zone and periods of remission. These are two very important signs and diagnostic features. Clinical examination of other cranial nerves to exclude other causes, it should be performed. Local anesthesia nerve block of the trigger zone will arrest pain for the duration of local anesthesia is effective. Then diagnostic aids like the CT scan, MRIs are used to exclude the presence of any tumor. Well, at times we prescribe them carbamazepine, and if the pain is controlled due to the carbamazepine, then it is diagnostic that it is trigeminal neuralgia. Differential diagnosis. Multiple sclerosis, it occurs at younger age, plus mainly it is bilateral, while trigeminal neuralgia is unilateral. Cluster headache occurs at night and it does not have any trigger zone. Post-herpetic neuralgia after herpes zoster of the fifth cranial nerve and history of skin lesion prior to pain aids in diagnosis. Then psychogenic neuralgia, the distribution of pain is unanatomical. It may cross the midline with no trigger zone. It is usually deep, vague, poorly localized. Well, neoplasia can also have like different types of their expression. It could be in the form of this type of pain. Intracranial neoplasms may cause facial pain if they irritate or compress the root of the ganglion of the trigeminal nerve. This may be indistinguishable from the idiopathic trigeminal neuralgia and is usually termed symptomatic trigeminal neuralgia. Then glossopharyngeal neuralgia, the pain is unilateral in the throat and base of the tongue on one side, sometimes radiating to the ear. So this is the difference from the trigeminal neuralgia. Then odontogenic pain, that is pain due to pulpitis or due to periodontitis or due to pericoronitis, etc., etc. Pain of osseous origin, like due to dry socket and acute osteomyelitis. Then joint pain, pain originating in the temporomandibular joint. Treatment of trigeminal neuralgia. Once we have the confirmation that it is trigeminal neuralgia, then what are the possible treatments available? Medicinal treatment, carbamazepine, I have already told you about it. Usually we begin with 200 milligram twice a day. Then second line drugs, if the patient is unable to tolerate the side effects of carbamazepine, or if the carbamazepine has been ineffective after 4 weeks, then the patient should be started with the second line drugs. The second line drugs are antileptic medicines like Dilantin and tricyclic antidepressants. Keep in mind, carbamazepine also causes gingival hyperplasia. If someone asks you, yes, carbamazepine can also cause gingival hyperplasia. Peripheral procedures, trigeminal neuralgia can be modulated by interruption of any part of the trigeminal pathway from peripheral sensory nerves to the nerve root entry zone. Local anesthetic blocks of peripheral nerves can be used as an emergency measure. Peripheral nerve destruction, usually by cryotherapy, then alcohol injection or nerve avulsion is used. The supraorbital, infraorbital, or mental nerves are commonly approached by the technique of nerve avulsion or by cryotherapy or alcohol injection. Ganglion procedures. Radiofrequency thermocoagulation, then glycerol injection in the ganglion, ballooning compression, and using the gamma knife radiosurgery, performing using the gamma knife. Surgical treatment, open procedures. Trigeminal root section, it is an intracranial surgery in which the sensory roots of Xarian ganglion are cut, sparing the motor root. Then microvascular decompression, or MVD, what we do, a loop of an artery, usually superior cerebral artery, which is resting on the trigeminal entry zone, causing the nerve to produce these symptoms. In this operation, the loop of the artery is dissected, elevated, and then a small prosthesis are put to separate the artery from the nerve. This procedure is known as Janeta's operation. Pre-trigeminal neuralgia. It is an aching dental pain in a region where physical and radiographic examination reveals no abnormality. Local anesthetic block of the tooth, it arrests the pain. Pre-trigeminal neuralgia responds to similar treatment as the trigeminal neuralgia. We begin with the anticonvulsant therapy like either carbamazepine or Dilantin. Now the glossopharyngeal neuralgia. It is a sharp paroxysmal electric shock type of pain which radiates from the oropharynx or base of the tongue or to tonsils, larynx, soft palate, ear, and mandibular ramus, or even to the region of TMJ. Clinical picture of this neuralgia is pain would be unilateral and of short duration. Well, swallowing, chewing, speaking, eating, and drinking can trigger the pain attacks. Pain is stopped by anesthetizing the pharynx with topical anesthetic where trigger point is located. Incidence of glossopharyngeal neuralgia. Middle-aged and elderly are mainly affected, more common among females as compared to males. Left side affected more commonly than the right side. Etiology could be vascular compression of the posterior inferior cerebellar artery on the root entry at the medulla. Differential diagnosis, Eagle syndrome, as there is a similar pain distribution and intensity in both the cases. But in Eagle syndrome, there would be dysphagia, foreign body sensation in the throat, headache and pain on turning the head to the other side. Treatment, carbamazepine and surgical decompression. So over here, we are done with our today's lecture on orofacial pain, and we will come back next week with the third part.